I would like to welcome my dear colleagues from different parts of the world. As we can see here, we have friends from every part of the world, China, India, and we see a lot of parts from the world. I'd like to introduce myself. I am a gastroenterologist from Cairo University. I work in the POIM and EST team in Cairo University. And Professor Okasha asked me to give a very basic lecture about EST, and we choose to when to do EST. Actually, when we started our program 2 years ago, we were just like digging through a wall. We have a lot of difficulties and barriers. We have some financial issues, we have some technical issues, and also we had maybe issues with the surgeons. But what we have noticed recently that we have issues with the referring doctors from our colleagues. We get a lot of referrals, but these referrals are usually not fit, maybe too small lesions for ESD, maybe advanced lesions for ESD. That's why we decided to learn together which lesion is suitable for ESD. So before we talk about ESD, we have to know from which ESD emerged. It emerged from EMR, which is endoscopic mucosal resection. As you can see, we just substitute few letters and now it becomes ESD. So just a gentle reminder, what is EMR? EMR is a snare-based resection. It's either you inject and cut the lesion or you suck and cut the lesion. EMR is safe and feasible. It's usually done by maybe most of the endoscopists, and you can do it at ease. But you can see this lady here. This lady is not happy with the EMR. Why? Not because she's a lady, and ladies are always arguing. Because EMR, it's not suitable for large lesions, as you cannot get in-block resection. So you will not have safety margins, either vertical or horizontal margins. Besides, there is a risk that will be a residual lesion, and this residual lesion may lead to recurrent lesions. And EMR is not suitable for non-lifting lesions, and it's also not suitable for recurrent lesions or any lesions with submucosal fibrosis. So if you just give it a little bit of thinking, of course, not like this guy thinking, it's just the limitations of EMR is indications for ESD. So here are the steps of ESD. ESD is, maybe most of you know, it's just you localize your tumor. You start by marking the lesion, then submucosal injection. Then you do circular incision outside the marking, and then you start dissecting below the lesion till you get your lesion in block. And this is the advantage of ESD. So here's, we start with a video that will show the steps of ESD. Here is a female patient, 42 years old, who were presented with GI bleeding. And during gastroscopy, this lesion was found. It's obvious that this is a submucosal tumor. And EUS was then showed that it arises from the second layer. And here's the video. You can see here's the lesion is on the lesser curve of the stomach, just below the esophagus. We start with marking using APC. I hope that the videos are okay. You start to mark the lesion, and afterwards, here's the marking complete. And afterwards, you start injection. We use methylene blue mixed with saline. After injection, we get the knife we will dissect with, and we start doing the circular incision. It's not mandatory that you complete the whole circular incision. You can leave a final part till the final dissection. And here you can see that we are performing the circular incision and it's almost complete. Then we start dissection. We start dissection. You can see here's the submucosa looks blue. I hope you can see the video clearly. And then we go below the lesion where we go for dissection. The lesion is on the left side. And we are just below the lesion and we are dissecting now. The submucosa has a very good affinity for the color. So it is the blue layer. This is the submucosa. Here is a very, very nice picture where you can find the lesion is on the left side. Here's the lesion that looks white. And here is the submucosa where we are performing dissection. And we are here almost near complete. We can use this needle also to inject. As you can see, there is a little bit of submucosal fibrosis below the lesion. And then we go on dissection. Oh, and then we encounter bleeding. If it cannot be controlled with a knife, we have to control it with coagulation forceps. And here's a successful control of bleeding, and afterwards it's almost done. It's just the final cut. Here we shift to the IT knife. This IT knife has an insulated tip knife. So we dissect with the shaft of the knife. As you can see here, that we are separating the lesion. And here is our final cut. So here's our lesion. And after that, it's very important to go to the bed back to be sure that you secured all the potentially bleeding blood vessels and your clean bed. And this is our lesion. Here's the pathology. It's a well-differentiated neuroendocrine tumor. And what's most important when you see the pathology, that you have to contact your pathologist and know if there is a free margin or not. So if we speak roughly about ESD, so it may be indicated for large lesions, maybe more than 15 in the esophagus, more than 20 elsewhere in the GI. ESD is indicated for lesions where EMR is not feasible, like recurrent lesion, residual lesion, non-lifting lesion. ESD is indicated when lesions, suspicious lesions that should be removed in block, because we have to get our safety margin, whether horizontal margin or vertical margin. Actually, this is very roughly speaking, but maybe we need to go a little bit deep to know which lesion is liable for endoscopic resection. So just a basic reminder about GI cancer and the wall or the layers of invasion to the GI cancer. Here's the wall of the GI. Here's the mucosa composed of epithelium, lamina propria, layer, and submucosa, the muscle layer, then adventitia serosa. If you have a lesion or cancer that is confined to the epithelium, it's called carcinoma in situ. When it starts to invade the lamina propria of the layer, it's T1A. When it goes to the submucosa, it's T1B. And then when it goes to the muscle, it's T2. To the adventitia serosa, it's T3. To the surrounding is T4. This is very important. This is the cornerstone of which to refer. Here you can see that endoscopy is limited to T1A and TIS, or T1A, and surgery from T2. So we have to know this by heart. Starting from T2 is out the scope of endoscopy. What about the submucosa? What about T1B? Why did I left it like this? Because the submucosa, they have classified it to T1B into 3 layers. The first 1/3 of the submucosa, the second 1/3 of the submucosa, and the third 1/3 of the submucosa. And actually what's debatable is the first, which is SM1. This is the first 1/3 of the submucosa, which can be liable for endoscopic resection. But on what basis do they choose that T1A and T1B SM1 are candidates for endoscopic resection? It's all about lymph node invasion. It's all about the risk of lymph node invasion. As you can see here, when you go from esophageal cancer to gastric cancer to colorectal cancer, if you go through the mucosa M1, M2, M3, you can see that the incidence of lymph node metastasis is around 0. We have to bear in mind that these numbers are not strict numbers. It's just a range of numbers, but it's usually around 0. When it comes to the esophagus here, maybe the incidence is a little bit higher. So when you go to SM1, you find that the incidence of lymph node invasion is a little bit higher. It can reach to 17%, provided that it's 200 micron. And for the gastric, it's 0%, but it's 500 micron. And for the colon, it is the whole SM1. So if we classify the indications here, we will find that in esophageal cancer, M1 and M2 are just an absolute indication. But when it comes to M3 and SM1, it's a relative indication. When we go for the stomach, also SM1 is a relative indication or extended indication. And then, and for the colon, it's free. So it looks like when we move down through the GI tract, things are getting a little bit looser or easier. So the rule that you want to get from this lecture is, as you go down from the esophagus to the colon, you can go for deeper resection. So as you go down, can resect more deeply. Okay, but it will not be practical if I bring all the guidelines in one lecture. I will need series of lectures. I just want to show you that it's not only the depth of invasion that is regarded as an indication for ESD. In each organ, we have an extra thing. I'm giving just an example. It's not the whole guidelines. And I will show you the links of the guidelines at the end of the presentation where you can go and check by yourself. For the esophagus here, this is adopted from the Japanese guidelines 2020, that they added the circumferential involvement of the tumor, whether it is circumferential or not, to decide if it is for endoscopic resection or surgery. And here's for the stomach, here's the ECGE and the Japanese guidelines both. They didn't depend only on the depth of invasion, they also added the presence of superficial ulceration, the size of the lesion, with whether it is differentiated or not. Here is a very interesting case. This lesion in the antrum, it was referred to our center after a trial of EMR in another center that failed. So we did an EUS and shows that this lesion is arising from the third layer. And here we are doing the steps of ESD. We start by marking. As you can see here, we use the MBI mode in the marking because this is a surface lesion. This is an adenoma. It's not like the other lesion that we have showed. It is a submucosal tumor. Then after marking, we can do injection. And then afterwards, we will go for the mucosal incision. And here's the circular incision is almost complete. And afterwards, we will go for dissection. And we usually start the dissection by deepening of the circular incision. It makes the lesion retracts. One of the problems that will be encountered during ESD in this lesion that is a little bit larger than the other one, that it will always just get over you while you are dissecting. So there are a lot of methods or techniques that we can use to retract the lesion and go behind. As you can see here, it gets smaller. And here is a clip retraction method where this is a dental flap that is attached to a clip. And then it is attached to the edge of the lesion. And you let your assistant gently push the dental flap, just forming a flap for you so that you can go down and you complete your dissection. At the end of the dissection, you can see that we have dissected the lesion completely. And this area in the middle is just submucosal fibrosis from the other trial, from the previous trial of resection. And here is the lesion. The lesion was shown to be completely benign. It's a tubular adenoma and a low-grade dysplasia. And of course, it has a free margin. So when it comes to colon is actually one of the most forgiving organs. Here is a statement stated by the ECG. It states that most of the colonic lesions or polyps can be removed by the standard polypectomy or EMR. And the ECG just confined the ESD just to measure two indications. First, for the lesions that may show suspicious of submucosal invasion and lesions that are not optimal for EMR. But maybe the Japanese were a little bit more bold and they put a lot of indications, maybe regarding bilateral spreading tumors, suspicious lesions, lesions with submucosal fibrosis, lesions with chronic inflammation, residual or recurrent lesions. And here you can see this is a laterally spreading tumor. This is the classification of the laterally spreading tumor. You can see here the lesions. This is the granular type, this is the non-granular type, and the granular type is classified into homogeneous and mixed, and the non-granular type is classified into flat and pseudodepressed. You can see here the lesions, the lesion looks very nice, and then you go down, this nice is disappearing. So for the first lesion, it can be removed with either piecemeal EMR or ESD according to the local experience, but of course ESD is much preferred because we want to get the lesion in block. But as you can see, as you go down here, the instance of invasion or the instance that this lesion carries a malignancy is higher. So as you go down, the indication of ESD increases. So here is a very nice video about a patient who has a laterally spreading tumor. It's a granular, it's mixed type. And can you see, when you see here, this is the granular part. And when we apply the narrow band, you can see here, this is the flat part. I hope the videos are okay with you. And then we will go with the classic techniques. We will start with marking the lesion. It's very important to mark the lesion here with the narrow band, as part of the lesion was not already obvious before the MBI moved. And it's very important that you clean your field very clearly and you inspect every part with narrowband or chroma endoscopy just to guess if there is a suspicious invasion or not. And as we finish our marking, we see that the lesion is big. It's occupying about 70 or 75% of the circumference. And then after the marking, we will go with the circular incision. As you can see, first injection, of course, and then with the circular incision. As you can see here, the circular incision, it's very nice demo because you just cut outside the marking so that you get a very good safety margin. And you can see here, after the circular incision, we start to go beneath the lesion. You can see this lesion, the submucosa is not very healthy. It's not like the blue, very good, nice one that we have demonstrated in the other two cases. This is because this patient has an ulcerative colitis. And then we go on for dissection. Of course, there are a lot of tips of tricks that we can talk about in colorectal ESDs. That first, you have to put the patient in a position where the fluid becomes an independent part. And here, there's the final cut. And then there is the lesion bed. The lesion is finally excised. And then, of course, you have to ensure hemostasis. This lesion is a raw area, big raw area, with a it may have a post-ESD bleeding. So here's our lesion that was removed in block. And then when we go for the pathology, it is a tubular adenoma with areas of tubulovellus adenoma with high-grade dysplasia. And there is a single focus of cancer, and it was invading to the SM1, and it has a free deep submucosal margin, which means that after we resected the SM1, there was 2 millimeter free zone of cancer. Here is the final diagnosis, where it's SM1 with 2 millimeter free vertical margin, and of course the horizontal margin was free. So my take-home message that ESD is to large lesions, suspicious lesions, lesions where EMR cannot be performed. It's no longer that all cancers are referred to surgery, because we see a lot of malpractice where patients with carcinoma in situ, after removing it, it goes for surgery. It's not for surgery from the very beginning. You have to remember that our limit is T1A. T1B is an extended criteria, or it's controversial. You have to check your lesion in details, and you have to know the layer, very important. And remember, as you go down, you can resect more deep. And at the end, you have to have a dedicated pathologist for the ESD, and you have to communicate with him. And finally, stay safe, stay at home. This is our team, and this is our dedicated pathologist, Dr. Dalia, and this is our backup surgery, Karim from Cairo University. These are the links. And thank you.